Good afternoon, respected professors and teachers. I sincerely thank all the professors and special thanks to my HOD, Dr. Csi Mc, for giving this valuable opportunity to present a case in this CSI program. So, starting with my case, my patient is a Mr. RK, 20 years old male, studying BSc second year, resident of Bihar. History was given by himself and mother, and it is reliable. He presented with the chief complaints of bluish discoloration of skin and mucous membrane since 7 months of age, easy fatigability and shortness of breath since 5 years of age, and episodic palpitations for 2 years, hemoptysis around 3 episodes 1 month back. Coming to the history of presenting illness, he was born as a full-term normal vaginal delivery with normal birth weight as told by the mother and asymptomatic till 4th month of age. Then he developed lower respiratory tract infection in the form of pneumonia, for which he required hospital admission for about 5 days. And he received IV antibiotics, after which pneumonia was resolved. However, no cardiological evaluation was done during that time. And as age progresses, mother observed a poor weight gain of the child. And at the age of 7 months of the child, then mother noticed bluish discoloration of lips and tongue while crying and feeding, for which child was shown in a government hospital Bihar, where after evaluation, he was told to have heart disease which requires surgery, but because of the financial issues, he was not underwent any surgery during that time. This bluish discoloration of the skin and mucous membrane progressed over a period of 2 years, and after that, the severity of the bluish discoloration was constant. There was no history of sudden worsening of bluish discoloration associated with increased shortness of breath, no history of any hospital admissions for the sudden worsening of the cyanosis, no history of squatting episodes in the childhood. He also had history of easy fatigability associated with dyspnea and exertion since 5 years of age, which is NVHA class 2, and shortness of breath was non-progressive in nature. Shortness of breath was not associated with any paroxysmal nocturnal dyspnea, orthopnea, not associated with chest pain or syncope. And it was not associated with any swelling of the limbs, abdomen, or yellowish discoloration of the eyes. He also had history of palpitations for about 2 years, which were episodic, sudden onset, at rest, which were not related with any activity. There are few episodes and they used to subside after giving an IV injection. However, the exact nature of the medication was not known to the patient. The palpitations were not associated with any giddiness, syncope, and not associated with. And the last episode of sudden onset of palpitation were 4 months back. And he also had history of hemoptysis 1 month back, which are about 3 episodes, and which are 1 week apart. Each episode, the quantity of the blood was around 30 to 50 ml of the blood, and it was not preceded by any fever or weight loss, and it was not associated with any increased shortness of breath or chest pain. So for this complaint, patient was referred to AIMS. There was no history of any prolonged fever, no history of headache, no history of blurring of vision, no history of joint pains. Coming to the past history, no history of tuberculosis in the past, no history of any hypertension or diabetes. Maternal history, no history of any hypertension or diabetes in the mother, and no history of any drug intake or fever with rash during the pregnancy. Developmental history, there was no significant developmental delay. Family history, father expired at the age of 33 years in a road traffic accident, and mother is a manual laborer. He had one elder brother and one younger sister. No history of similar complaints in the family members, and no history of tuberculosis in the family members. Personal history, mixed diet, and he is unmarried and no addictions. Socioeconomic history, he is living in a pakka house with 2 rooms, belong to lower middle socioeconomic class according to the modified Kupaswamy scale.
Can you summarize your history, Vijay?
Yes, ma'am. So to summarize, my patient is 20 years old male with history of pneumonia at 4 months of age, with poor weight gain in childhood, and there is a progressive cyanosis since 7 months of age, with an history of easy fatigability and non-progressive shortness of breath of NVHA class 2 since 5 years of age. with an history of arrhythmic palpitation for about last 2 years, and recent onset of hemoptysis around 3 episodes 1 month back, with an history suggestive of patient having congenital heart disease with that required surgery at the age of 7 months.
Why do you say arrhythmic palpitations?
Ma'am, it is non-exertional sudden onset, which are used to start at rest, ma'am, and used to few subside to be spontaneously and few with after giving IV injections, and it was not related with any activities.
Okay, so just tell us your hemodynamic interpretation and the possibilities in terms of diagnosis based on the history alone.
Yes, ma'am. So this patient developed cyanosis at the age of 7th month, which is preceded by history of pneumonia with poor weight gain. So likely, I was thinking cyanotic congenital heart disease with which was initially started with increased QP. The symptoms initially had increased QP symptoms like pneumonia with poor weight gain, and after that he developed cyanosis. And the recent onset of hemoptysis also. So
would you like to place him in the congenital cyanotic heart disease group?
yes, sir.
Okay, then from the history, you have not yet done the clinical exam.
Sure.
Is it suggestive of decreased flow or increased flow?
Sir, patient started with increased QP, sir, because he had poor weight gain along with history of pneumonia that required hospital admission. So I was thinking it was increased QP, CCHD with increased QP initially.
Don't you think that the duration of cyanosis, if you are thinking in terms of an acyanotic heart disease later developing cyanosis,
Sir,
whatever reasons, then looking that the time interval is a little short, that is an odd point, I thought, because there was no cyanosis to begin with, and at 7 months the mother has noted cyanosis, which would first put you this thing on. Is it cyanotic congenital heart disease or an acyanotic heart disease later developing cyanosis?
Sir, usually acyanotic congenital heart disease developing cyanosis like Eisenmenger physiology, usually with plain shunt lesions will have develop cyanosis in the first decade or second decade, but complex congenital heart disease with both admixture as well as transfusion physiology, they can have early onset of cyanosis, sir. So we initially started with increased QP, then they can develop Eisenmenger later to develop cyanosis.
Your history initially was more in favor of an increased pulmonary
blood
flow.
Yes.
Why do you say so? Because you've just got one episode of pneumonia and cyanosis occurring early.
Yes,
so
sir.
Then when cyanosis is occurring early, meaning at 7 months of age, and increased blood flow situation,
Sir.
What kind of conditions come to your mind which will permit you a survival up until 20 years of age? And when typically a simple VSD Eisenmengerized would get, we will see cyanosis for the first time?
Sir, actually, simple VSD, large VSD, they to develop cyanosis in the infancy is very, very, very rare, sir. And usually they will develop Eisenmenger by 2 years, and they will develop cyanosis in the first.
Develop Eisenmenger at 2 years is not a right statement. They may start developing pulmonary vascular obstructive disease at 2 years,
yes,
but many of them still remain operable at 2 years also. So it is only the start of onset of PVOD. Full-fledged may develop later, and as you rightly said, the cyanosis comes much later in the first or the second decade.
For a
actually,
high blood flow situation, when you have got cyanosis, which is in infancy.
Praful, you are not properly audible. Be louder, please.
Yeah, within 7 months, you are getting cyanosis. So what conditions are coming to your mind? When you say Eisenmenger's, first thing that comes to your mind is VSD pulmonary hypertension, Eisenmenger's, right? So can it be a simple VSD Eisenmengerized?
Unlikely, sir.
Unlikely. So at which of these 3 levels are you thinking about?
Sir, I was thinking there should be not only the simple lesion, but also admixture physiology should be there, sir.
So what admixture physiologies do you know of for them to be there in this pattern?
Yes, sir.
Like that,
like single ventricle or double outlet right ventricle or total anomalous pulmonary venous connection.
Okay, what about AV canal?
AV canal.
Common atrium.
Common atrium and tricuspid atresia with VSD without PS.
No, I think Vijay, common atrium will not develop Eisenmenger so
Yes.
early. You cannot include common atrium in this group. So is AVST. AVST is primarily a VSD plus AST.
History with Eisen.
They will not develop Eisenmenger at 7 months. I think the point that you are missing over here is that the cyanosis has been noticed at 7 months.
7 months.
It's very likely that cyanosis has been there all along. So you cannot discount that cyanosis was not there. Parents don't notice it unless it is, significantly cyanosed. So if the saturation is in 88, 90%, it may be totally missed at the bedside.
Yes,
So
ma'am.
can this be a TAPVC? Let's often just talk about, can this be a total anomalous pulmonary venous connection?
Yes, sir. It can be total anomalous venous connection can be a possibility, sir, based on the history.
Vijay, I missed one thing. You have mentioned that the child required surgery at the age of 7 months.
Yes, sir.
Is there anything revealing from the history whether the nature of the surgery was given to him or parents that he will require another kind of surgery later on, or this was the total surgery done? Any idea was given in the history? I think you can extract that history at least.
No, sir. Actually, mother was able to tell that the surgery was required, but she didn't know the exact nature and she didn't elaborate like.
Is she sure that it was a heart surgery?
Yes, sir. She told it was a heart surgery. He had heart disease and required surgery.
And she was not told anything about the step 1 surgery or step 2 surgery?
No, sir.
Okay.
Actually,
why can't this be a low pulmonary blood flow situation? I am telling you, this is garden variety tetralogy of fallow. So what is against in all this history that you talked?
Sir, tetralogy physiology, the typical physiology, like it will be VSD with pulmonary stenosis. So here the patients to be started with increased QP symptoms like pneumonia and poor weight gain, sir. So that is against of
pneumonia, poor weight gain. He has had one episode of pneumonia and
yes,
he is the undernourished person. That's about it. So what is there? Where is there any history suggestive of any heart failure like physiology in childhood?
Another thing, Vijay, as sir is saying about any other history of heart failure, that is thing. Another thing I am mentioning here, that you are telling that they are from the lower socioeconomic country status. So it could be nutritional deficit as well, rather than failure to thrive due to other reason.
So yes. Are you totally ruling out tetralogy of fallow? I'm telling you that cyanotic heart disease in the adult, and this because there are no squatting episodes, because there are no spells, is what you want to say?
Yes, sir.
Then having said that, do you get squatting episodes with Eisenmenger physiology also?
Yes, sir. We can. Child can get squatting episodes even in Eisenmenger, sir, but it is very less percent. Around 3 to 5% of the children can develop with Eisenmenger can develop squatting episodes, sir.
So what is against tetralogy of fallow here?
So I was more not putting tetralogy of fallow because of the episode of pneumonia with poor weight gain, and there were no squatting episodes or cyanotic spells, sir, in the childhood.
One episode of pneumonia, Vijay, again can be happening in any child, with or without heart disease in our status, and whether it is recurrent LRTI or something like that.
No, sir. Only one episode, but that required hospital admission. So definitely it is significant. But if we disregard that pneumonia, if we attribute that pneumonia due to poor nutrition, then definitely
there are many cases in the pediatric ward without any heart disease. They are getting admitted with RTI and getting discharged subsequently.
So Vijay, I think you should not rule out cyanotic heart disease with reduced pulmonary blood flow. Although your first diagnosis is right, it should be considered as increased pulmonary blood flow. But remember, the reduced pulmonary blood flow group is far more likely to survive to this age.
Exactly.
And therefore, please don't disregard that diagnosis. You can put it as number 2, but you cannot say that you will rule it out based on the history.
Yes, I do agree. I think that's a very, very valid point. Okay.
So, you've got this is your differential diagnosis?
Yes, ma'am. So second possibility I'd like to keep top physiology also, as you said, ma'am.
Yes, I think you should. And of the increased pulmonary blood flow going on to Eisenmenger, like the one you mentioned, are fine. you really cannot have a preference of one over the other.
Is it? That's a typo out there. Decreased. You mean increased?
Yes, it is decreased now. No, it is Eisenmenger now.
Yeah,
He started off as increased.
Now you're telling. Okay.
Yeah, it decreased now. So it will also come as decrease for the blood flow. But what I'm saying is between the various differentials that you've given, there's really not much to choose from. But I would like to ask you in terms of survival. I think at this point of time, you have to just think in terms of survival, that which is likely to survive. For example, you haven't placed transposition over here, and I would say rightly so, because that has the worst survival.
Worst survival.
Yeah.
Another thing regarding truncus, do you think surgery can be done in a peripheral center with truncus surgery? That's a bit difficult surgery.
Anita madam, here DORV VSD with transposed arteries, you're actually meaning a subpulmonic VSD, right?
Yeah, are you meaning thoracic beam?
Then along with that will be transposition. I don't think that is first on cards. If you say transposition is not first on cards, this is DORV VSD non-transposed vessels.
Yeah, but they definitely have a better survival than the transposition.
They have, but you shouldn't be mentioning DORV VSD with transposed great arteries. That's same as transposition.
Yeah, it is Csi Mc he's talking about.
This was the thoracic beam. Yeah.
It's Csi Mc he's talking about, which definitely has a better survival than the TGA VSD itself. Okay. So DORV definitely is better than TGA. But regarding truncus, I don't know, Vijay, you want to answer that question? Can it be operated in a, is it easy to operate? Would you advise surgery for a truncus?
Ma'am, at the age of 7 years, likely he might be got operated, but not at the periphery center, ma'am. You might have referred to some tertiary care center where.
You mentioned 7 months or 7 months?
7 months, sir.
So I don't think it is an easy surgery. If it is an increased flow situation, only bending something like that, though we do not know about the center. That type of surgery are done in the peripheral centers.
I think
so I would like to put single ventricle ahead of truncus. Maybe the last one.
Single ventricle
has a better survival overall.
Okay.
Go ahead, please.
Go to the examination now.
Coming to the examination, patient conscious, oriented, comfortable at rest, thin built with BMI of 16.4. kg per meter square, and on general physical examination, patient is polycythemic. There is uniform central cyanosis with grade 3 clubbing both upper limbs and lower limbs. There was no icterus, no pedal edema, no lymphadenopathy, no markers of infective endocarditis with normal dental hygiene. Coming to the vital examination, pulse rate was 72 per minute, regular, normal volume with no special character. All peripheral pulses were felt, no radial or radiofemoral delay. BP, right, blood pressure was right upper limb 120 by 80 mm of mercury, with right lower limb 128 by 78 millimeter of mercury. Respiratory rate 18 per minute, regular, abdominothoracic, and temperature febrile 98.8 degrees Fahrenheit, right axilla. Saturation right upper limb was 81%, left upper limb was 80%, and right lower limb is 81%. JVP was not elevated, and the hepatojugular reflex was negative. Coming to the cardiovascular system examination, on inspection, trachea appears central, no precordial bulge. Typical impulse is seen in the 5th intercostal space in the midclavicular line. Parasternal pulsation seen in the left, second, and third intercostal space. There were no epigastric pulsations, no dilated veins or scars.
Did you search for operative scar?
Sorry, sir?
Did you search for a operative scar well?
There were no scars, sir.
See, in the conditions that you have described, till up to the JVP, can you rule out one condition depending on the JVP findings? You have listed some differential diagnosis. So, if the JVP is normal, can you rule out one of the conditions? Because you said tricuspid atresia is one of the conditions. So JVP is absolutely normal according to you. So probably tricuspid atresia can actually be excluded from this condition, isn't it?
Yes, sir.
Okay. Yes. Now, if your JVPF written is not elevated, then I would consider that tricuspid atresia comes much lower in the list of differential diagnoses that I would be discussing. Okay, go ahead.
So, on palpation, trachea was central, apex bit felt in the 5th intercostal space in midclavicular line, LV type, heaving character. There was palpable second heart sound, systolic thrill was present in left third and fourth intercostal space with grade 2 parasternal heave present. On percussion, right heart border retrosternal and left heart border correspond to apex. Left second intercostal space was dull. Liver dullness felt in the right fifth intercostal space with liver span of around 10 centimeter, and trough space was resonant. And coming to the auscultation, S1 was normal. S2, P2 loud with narrow split S2.
Can you hold for a minute? Just from the palpation, do you think is a univentricular pathology or a biventricular pathology?
Sir, it is LV type with heaving character. Likely it is biventricular pathology, sir.
So from only heaving effects or parasternal heave is also giving some clue?
Yes, sir. Parasternal heave that also indicates RV overload along with the LV heaving type of character. So both including.
Could you locate any zone of retraction in between?
Sir, there is a middle retraction from the.
Are you sure about it, or on my asking you are saying it? Please?
No, sir. Based on that only, I thought it is LV apex.
No, hang on 1 second. At this stage, single ventricle, madam said that would be a more commonness to survive up till here. Now, yes. Can this be a single ventricle? At this stage, let's not go to your auscultation or nothing.
Sir, as Sarah asked, I'm able to feel the LV apex with heaving character along with medial retraction, and it was not continuous with the left parasternal palpitations with grade 2 parasternal heave. So likely it suggests of biventricular pathology, sir. We can rule out single ventricular pathology.
I think, Vijay, that is being, I would say, very, very dogmatic about it. Tell me the conditions of cyanotic heart disease where you have an LV apex. Just enumerate them.
Yes. Ma'am, tricuspid atresia and single ventricular with predominant LV morphology, or those conditions which are having restrictive ESD like DORV.
Yeah. So I think you should not say that you can rule out single ventricle or you must have two ventricle physiology. I think having an LV apex is very unusual for any cyanotic heart disease, and therefore you should restrict yourself to tricuspid atresia. Even in JVP is okay, and single ventricle.
And AVSD with predominant left AV are also.
So if it is tricuspid atresia, how he should feel the parasternal heave?
Yeah, so that's what I'm saying, that these are, having a parasternal heave, whether it is in continuation with the apex is something that you also, somebody asked for. So having parasternal heave and LV apex is a very unusual finding in a cyanotic heart. It's possible that he may be wrong, and therefore I would not put all my money on left parasternal heave. I would be more confident of the apex than of anything else. And therefore I would say that please do not make it two ventricle just based on this finding.
Again, single ventricle wise, that second heart sound, second space pulsation, you're palpating a second space something there. What about great arterial relationship for the kind of single ventricle that you're expecting? Is it a malposed aorta, or are you talking here about Holmes heart, or are you talking about normally related great arteries? Let's go along that it is single ventricle at this stage. You can't be dogmatic as what madam says. So what do you expect here? In the second left intercostal space, are these pulsations of a malposed aorta or a pulmonary artery there?
Sir, with overall case scenario, I was thinking it is pulmonary artery only, sir.
Okay.
With next examination.
Now tell me, in a single ventricle, what kind of malpositions are described of the great arteries? The commonest single ventricle that you see, what is it like? What do you get to see? You heard about outflow chambers, you heard about malposed great arteries, is that right? So
yes,
what do you get to see when you get single ventricle PS, for instance?
I'm sorry, sir.
Vijay, how often you get normally related great arteries in single ventricle?
Single ventricle.
First answer that question.
That actually usually rare, ma'am.
Rare. So it is about 3% or so. Yes. So of these 95, 97% which are left, you obviously have only a couple of ways that the great arteries could be malposed. They could be demalposed, they could be L malposed, or they could be side by side. So which is commoner of the two, and why we are worried or why we are concerned about second space being dull?
So if the left second chord space is dull, likely maybe the second space it will be aorta, ma'am.
Yes. So in patients of pulmonary stenosis, here of course you have an argument to say it could be pulmonary artery because you are talking more in terms of pulmonary arterial hypertension.
Yes.
But in a patient who has pulmonary stenosis, if you have second space which is dull, it is likely to be L-post aorta.
L-post aorta, yes.
Yeah. So that is the question being asked to you.
So by and large, single ventricle, correct me if I'm wrong, madam, single ventricle high blood flow situation coming into adulthood, if it has to come to this level, it has to be normally related great arteries one. The Holmes heart is what they call it, right?
I mean, I think the most single ventricles that survive to adulthood are the ones which have just a balanced amount of pulmonary stenosis.
Yes.
And they are the ones who maintain a saturation of 85-90% and come on to the adulthood. Holmes heart is itself very, very rare. I mean, it's, as I said, it's less than 5%. Therefore, based on that 5% to say that people who are surviving are likely to be Holmes heart will be tough to say. So I would say that most often single ventricle, L-post aorta, pulmonary stenosis of the right kind are the ones who survive.
Are ones who would survive up until here.
Madam, you said that another lady is going to present the investigation. Has she also been involved in the examination part?
No, she doesn't. In fact, she knew about the case earlier on, but Vijay doesn't know anything about the case. So we gave her to present the investigation. Vijay will only interpret. She will only show.
Okay. Go ahead, Vijay.
So coming to the auscultation, S1 was normal, S2, P2 loud with narrow split S2. There was very loud, long, grade 5 ejection systolic murmur along the left sternal border in third and fourth intercostal space, harsh in character with mid-systolic peaking and radiating throughout the precordium. And there were no other sounds and no murmurs at the back. And other systemic examination was normal.
Situs, clinically situs solitus.
Yes.
Did you get any click?
No, sir. I couldn't get any click, sir.
Okay.
So why did you put DOR with a restrictive VST as the first possibility?
Sir, the cyanotic congenital arteries with the LV apex, which is having heaving character, likely it has to be restrictive VSD, sir.
Vijay, why it is not tetralogy?
Ma'am, there is a clear-cut P2 loud with palpable P2 and very loud, long, harsh ejection systolic.
No, what you are hearing as P2 is A2. It is not saying that I am P2. It could be A2. Loud A2 is well described in tetralogy patients.
Again, it comes to a second space
pulsations and
pulsation.
palpable P2 that cannot be expected. And,
no, Vijay, my point is what you are saying palpable P2 is a juxtaposed or dextroposed aorta, relatively anterior aorta that you get in tetralogy with overriding. So is A2 not loud in tetralogy? It could be A2.
It will be loud.
It could be A2. Why are you saying it is P2?
But two features. One is predominant thrill with this harsh quality, very long ejection systolic
murmur. Patient is not very blue, so you have a loud murmur. Typical tetralogy. Because what the diagnosis you are making is much rarer than tetralogy, no? You have to think in terms of the likelihood of a diagnosis.
LV apex also.
Yes, that is what you didn't say. So you must say. Yes. That is why I was giving so much emphasis onto LV apex. That apex being LV is a very, 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 very important finding in any patient of cyanotic heart disease.
I would have thought that you would put a single ventricle physiology as the first possible rather than DOR. DOR, I agree, but statistically, I think probably, Anita can correct me, statistically, I think single ventricle probably would be a little more frequent than DOR.
You have mentioned NSR, that is, I think it is normal sinus rhythm.
Yes, sir.
Is it so?
Yes, sir.
So from the clinical exam, you examine the pulse, you examine the JVP, etc. So how do you say it is a NSR, not other kind of regular rhythm?
Sir, based on regular rhythm only, I put sinus rhythm, sir, but it can be like junctional rhythm with regular. Yes, sir.
So, how can it be junction rhythm? Are you not seeing A followed by B in every JVP?
Actually, I couldn't appreciate the waves properly. The AVP is not elevated. Even in the lying down position, I was not able to appreciate the waves
I see.
properly.
So you don't see unless you appreciate JVP,
So
you
is he
cannot
dehydrated
write
that
NSR.
even in the lying down position, he is 20 years old? Do you think he is dehydrated that you couldn't look into the neck vein, or any other problem in the neck is there so that you could not examine the neck vein? It's not a baby.
There was no problem with the neck, sir, but I couldn't appreciate properly, sir. So,
see, if you cannot appreciate JVP, you cannot write NSR.
How sure?
Interpretation is only regular rhythm of such rate.
okay, sir.
How sure are you regarding the split also? Usually, in most of the cases, it is very you get only a single second sound. So you have emphasized on the split second sound.
It appears narrow to me, sir. There are two sounds definitely with narrow.
Okay.
So if you're very sure of the second R sound, I would agree with your diagnosis. But very often you are not, and therefore it will be good to keep single ventricle PS or a tetralogy-like condition with such a loud murmur. Such a loud murmur is, something which is very, very rare within Eisenmenger physiology.
And why do you suspect PVH to be there?
Sir, patient is having NVH class 2 symptoms that can be due to sinuses also, but I'm suspecting a restrictive VSD. So likely it should have at least mild PVH, sir.
No. What is your symptomatology suggest? You categorically said no orthopnea, no
no PND. Yes.
Yeah. So what else can clinically? There's no way to try to diagnose that otherwise. No, just to guess PVH on the basis of what you think is a restrictive VSD, etc., is not on.
That's why I put query mild.
But
PVH.
You said patient is dyspneic. So could dyspnea be because of anything else other than PVH in this case?
Yeah, the sinuses, hypoxia itself can produce the NVH class 2
So interpret PVH, dyspnea as PVH is okay for an acyanotic person, but for a cyanotic patient, it's not a good idea.
Yeah.
So there are several pointers.
Could you just go back one slide and just tell me your auscultatory finding? Just 1 second. Very loud, long, grade 5 ejection systolic murmur. Okay, good. Yeah, come back to that diagnosis.
So Vijay, I would still keep one diagnosis. I mean, the diagnosis of tetralogy for the LV apex, you need not keep tetralogy itself, but you could keep single ventricle or an AVSD with the dominant being left ventricle with the pulmonary stenosis. Because having such a loud murmur, grade 5/6 in a cyanotic patient, you should not ever move away from tetralogy. If you don't diagnose tetralogy, you're probably not going to be right 90% of the time. So this is a rare diagnosis that you've made, and rare diagnosis should always be with the differential diagnosis.
This degree of murmur we get in very relatively, so-called pink fallow or similar type of situation where PS is minimal. So I think everything is not matching.
Yes, I agree. I think having such a loud murmur, in fact, there is a question from the audience also that how do you diagnose Eisenmenger syndrome in somebody with such a prominent systolic murmur? And that is the question that everybody is asking. We agree with you, Vijay, that you can explain it by a restrictive VSD, but restrictive VSD is a very rare situation in a DORV, much less than a tetralogy situation, and therefore it should come only as a second diagnosis. That is all I was trying to make a point. You may be right having DORV restrictive VSD, but that should not be your first diagnosis.
So in a cyanotic, if you're saying 5/6 murmur, it has to be necessarily low pulmonary blood flow situation from this thing. I don't know why did you ever go down this line of a high blood flow situation just on one episode of pneumonia. When in the history, there was nothing to go along high pulmonary blood flow situation otherwise. Yeah.
See, one thing is that you said there are pulsations in the second left intercostal space. If it's a reduced pulmonary blood flow situation, can this happen?
Sir, abnormally dilated pulmonary arteries like top with absent pulmonary valve can have the pulsations. Like.
But then the murmur will also be different.
Typical
You can even give us saying that because you are finding
not as palpable.
So
in an absent P valve, the pulsations are not as much palpable as they are. You might get dullness there, but that's a low pressure pulmonary artery, right? Thing.
So this is your provisional diagnosis. Any differential?
Sir, I thought because of I gave a lot of money to heaving apex, sir. So with heaving apex, I can't put.
Why not single ventricle with PS?
That's what I said, that initially my first choice would have been a single ventricular physiology with an LV type of apex rather than a DO or with just lesser, especially with this murmur, which is so loud. See, if you are putting restrictive VST, then your explanation for pulmonary hypertension and all will be a little tenuous.
And another thing is that PS again is with malposed great arteries by and large, right? So that pulsations and all, everything could be the malposed aorta.
Another thing is that whenever you are giving a single diagnosis and these are not matching with any fixed diagnosis you have given, so either there are differential or you have to discuss the diagnosis. You cannot diagnose it properly. So there are certain probabilities or possibilities you can discuss. So you are at the one point you are giving only one diagnosis, and the other hand we are finding that the findings and history are not matching. So it is a difficult situation.
Yeah, I agree. I think the first diagnosis to me will be single ventricular pulmonary stenosis with an L-post aorta, which can give you pulsations in the second left intercostal space, which can give you LV kind of apex. Yes, the history is a little odd in terms of failure to gain weight, but as we discussed that it can happen in our sort of, population that we deal with, and therefore putting all your money on that may not be a good idea. But to have a grade 5 murmur in an Eisenmenger is the most unusual thing, and therefore you should make it as a second or third diagnosis.
Another thing, ma'am, is that if it's a univentricular heart, he has to revise his diagnosis of finding up this zona medial retraction. The whole thing should be continuous from right to left.
Yes. I agree, but I think between the various signs and history that we have, we'll have to pick and choose which one we take as of more significance compared to those which can be ignored. So I would say that to have grade 2 left parasternal, I would go back and check if I'm right or not. Having an LV apex is to me a very, very
the other
significant
thing is that
finding
maybe one or two
patient,
findings he has made it wrong. That one or two findings is not.
That's what I'm saying. Like he's saying narrow split with a loud P2. I can interpret it as just a loud single second heart sound being A2. And sometimes when you have a very loud heart sound, then you may have a little bit of a reverberation with it, which may appear like, you cannot put all your money on that.
Another thing, Vijay, I just pointer, I'm not saying that diagnosis is there. In truncus, we get the reduplicated second sound, but it is truncus is not matching.
Truncus here would have necessarily had an EDM there along with it. Truncus regurg would have been
No, I told it is not matching. Yeah.
In the adult, there are no diastolic murmurs at all, right?
I think it's the most important point in the physical finding is that LV apex, which you are very sure of. I think as Dr. Anita said, this is one solid finding where probably there will not be difference of opinion between people, and also the second thing is that murmur, where very loud murmur you cannot miss. So these are 2 points which we have to bank your diagnosis on. So that's why I was initially thinking that with Dr. Anita that it would be a single ventricular physiology as a more likely possibility than DORV. Okay, I think.
Vijay, you have a chance now. You can have another diagnosis. So I would suggest that you make another diagnosis in this particular case. What it would be?
It will be like CCHT with decreased QP, single ventricle with PS, and then NVH class 2, no CHF and no infected endocarditis.
Yeah, you should think of tricuspid atresia also one can think of, but a little little unusual with the JVP being absolutely normal in an adult. Although in child JVP can be normal, but in adult having normal JVP is a little unusual. And also tricuspid atresia has a worse survival than single ventricle. Okay, shall we go to the investigation? Yeah. You can stop sharing, Vijay.
Yes.
So chest X-ray PA view with the distance between with slightly rotate to the left side with good inspiratory film and with adequate exposure, showing a CT ratio was around 0.5. There was no cardiomegaly, and the LV apex is looking like LV, and there was no eye enlargement, but cardinal angle appears slightly enlarged, maybe around 90 degrees, likely maybe LE enlargement, and pulmonary trunk is very prominent, with right descending pulmonary artery also prominent, and there was peripheral proning, sir, suggestive of PAH, and
is there PBH?
Looking like there is slight cephalization is there, ma'am. So likely some PBH.
Are you sure about cephalization, or these are branches of pulmonary artery? How do you differentiate?
Sir, we should trace along with the bronchus, sir. If it is going along with the bronchus, likely it is pulmonary arteries rather than the pulmonary veins.
Can you trace along with the bronchus? Is there any bronchial marking? Because their translucent shadow, until unless something there is to trace the bronchus, it becomes difficult. Yes. Another thing, you could retrace back the pathway of the vessel. Around veins.
I think there is a cephalization in the upper part of the lungs, and therefore, and they're not looking like pulmonary artery branches the way they're going. You know, those typical reverse mustaches as we talk about.
Yeah, probability is there, but is there any way to be dogmatic? That is the thing.
No, I agree.
Yeah, because on the one side there is so much of PAH, and at the same time PBH is still there. So again, this should be a very complex pathology. Yeah.
I think if he's going
have
with
you measured? Of course, you are not having the scale. RPA diameter, lower.
Vijay, why do you say RPA is dilated? Based on what?
Ma'am, it visually appears right descending pulmonary artery is dilated and sudden tapering was there. So
no, when do you say it is dilated? What is the definition?
We should measure just 1 centimeter below the hilum. If it is more than 17 centimeters in male and 16 centimeters in female, it suggests of dilated.
You think these measurements hold true in digital X-rays as well, when there is no scale around?
No,
so how do you diagnose it as dilated? You have to compare it with some part in the lung, in the X-ray itself.
So, the peripheral compare the bronchus.
Yes.
Bronchus.
So you should say that, because having 1 centimeter or 17 millimeter is something that you won't be able to say in a digital X-ray.
Yeah.
So and then you also said tapering of the right pulmonary artery, descending pulmonary artery. Yeah. Which is suggestive of
severe PH, ma'am.
Yeah.
But peripheral vascular markings are well seen, no? If you look at the right side and the left side.
It appears actually prone, sir. Peripheral 1/3, it is like very barely
I
visible.
think the question over here is between PS and PAH, because this is one of the one of the two diagnoses we are considering. We are not really considering large flow situation without PAH over here or without Eisenmenger. So between the two of them, I think it's quite clear this is unlike a tetralogy X-ray or a tetralogy physiology X-ray. It's more in favor of an Eisenmenger X-ray. So between the two diagnoses that you made, Vijay, I think you need to stick more with an Eisenmenger physiology rather than a tetralogy.
Can you see the aortic?
Yes, yes, sir. Actually, just above the right atrium, you can able to see the ascending aorta, and just above the pulmonary bay.
No, you are being asked a very specific question about aortic arch. Which side aortic arch is it?
Left or right?
Left side, sir.
Why do you say that?
Ma'am, there is a indentation on the left side, ma'am, on the trachea.
So that's a simple answer.
Yeah.
Okay.
And there is no right atrial enlargement. Again, tricuspid atresia, one point against the tricuspid atresia again would be an absence of a right atrial enlargement. So it may be a very soft sign.
Only thing is that if you have juxtaposition of atrial appendages, then the RA kind of goes away from the usual place. It comes behind the sternum, so you may not appreciate RA enlargement. Yes. If it is juxtaposed.
Yes.
Can you appreciate certain prominent end-on appearance of the pulmonary artery branches?
No, sir. There were no prominent end-on vessels. I'm able to appreciate there.
Near the right hilum?
Actually, the X-ray is not actually what I was really expecting. It's a slightly odd X-ray.
Yeah. Too many vascular markings.
Yeah. No, one cannot say that it has decreased pulmonary blood flow, increased pulmonary blood flow. But I would also go more in favor of an increased pulmonary blood flow initial situation rather than a decrease.
As in infancy,
there are some end-on vessels in the right hilum. I agree with that.
Pointing out.
And therefore, again, it points more towards Eisenmenger situation.
And as there is history of congenital, surgery in the 7th month of age. So, is there anything to be looked on the ribs also?
He hasn't had surgery. He was only advised.
Surgery.
He was only advised.
Oh, acha.
Okay.
Okay, ECG. Can we have the ECG?
1 minute, sir.
Fourth channel ECG showing the speed of 25 mm per second with normal standardization, with lead V1 showing P wave upright and AVR showing negative P wave, so situs solitus, and normal R wave progression, so levocardia, and sinus rhythm with QRS axis. Lead 3 is biphasic, so lead 2 also positive, so likely 45 to 60 degrees normal axis with there is no right atrial or left atrial enlargement, and R wave in V5, V6. So evidence of LVH, but there is no strain pattern, and V1 is not showing any predominant R wave, so no RVH.
But also you should say no monomorphic complexes like you sometimes see in single ventricle patients.
Okay.
There is a clear transition in V2, V3.
Yeah. Sudden transition.
There are Q waves in 2, 3 and AVF and in V5 and V6. Is there any, it's a little odd. I don't know how to explain
that. 2, 3 AVF Q waves indicates clockwise rotation, which you used to see in most of the congenital heart disease.
I think Q wave in V5 and C6 and then R in V1 will probably rule out, atrioventricular discordance or ventricular inversion. Yeah. Because you were considering about single ventricle with L-post aorta, you would expect absence of, you would not expect.
So what goes out now? Everything else is out, right? Meaning single ventricle.
After the ECG and X-ray, in the backdrop of the clinical history and findings, which diagnosis would you like to keep in after seeing the ECG and X-ray?
Sir, with
So one thing everybody was thinking about a top situation. Do you think it is still there?
no, sir. Unlikely it is tough, and on X-ray it is more of Eisenmenger, looking like Eisenmenger physiology, sir, rather than
Eisenmenger physiology secondary to
secondary to
with a split second sound.
Yeah, but but you have a normal axis, you have no definite evidence of RVH.
That is not expected, sir.
These are all unexpected things in a Eisenmenger, isn't it?
Yes, yes.
R
dash in V1, that's the only RV that we have here, right? And also S in V6 going till there. So is it biventricle, this thing?
Yes. See, if you look at V5, V5, I think it's Katzwash or something. V4, V5, biventricular.
Like there is biventricle here.
V3 to V5, there is predominant RS complexes, sir.
Yes.
So maybe.
So this ECG had a split second sound. Forget your murmur and everything. Just this ECG had a split second sound that you can hear in an Eisenmenger patient. So what comes to mind? Can this be a ductus arteriosus Eisenmenger? Just the ECG.
PDA. So presence of Q waves in lateral leads usually suggest of PDA with Eisenmenger, sir, like V5, V6. So it can be.
No, I wouldn't agree with that. You should have right axis deviation. You should have dominant right ventricular hypertrophy. If somebody is turned blue, there's no question about LV volume overload staying over. So you should have RAD and RVH pure if it is Eisenmenger, whether it is VSD or PDA. I mean, if you have LV forces, then patient should not have been blue if it was PDA PH. I think I would still say it fits with single ventricle because single ventricle can have any type of ECG. So I would not rule out single ventricle of, with this ECG. Yes, X-ray is against tetralogy. I would agree.
Actually, at times the outflow tract in the single ventricle, actually, basically they are known as the univentricular pathology, can produce some right-sided impression besides the left-sided. So there may be apparently two ventricles due to the non-dominant ventricle. So yes, this may be still a univentricular heart that has got different types of univentricular heart.
But still with a bulboventricular foramen causing that murmur. This is a PSPH scenario. Is that what you're hinting at? Meaning, where is the murmur coming from?
No, we are saying, what I'm saying is that in single ventricle, the ECG can be anything. And therefore, of the two diagnoses that he made, single ventricle PS could have been a diagnosis, but X-ray is against it. X-ray is pointing towards Eisenmenger syndrome.
One question to all the examiners. Should we or can we entertain a diagnosis of Eisenmenger's without any right ventricular forces as is this ECG?
Exactly. But he's blue, absolutely blue. The child is
so the diagnosis must be something else.
No, Vijay has made it Eisenmenger with restrictive VST. And once you think of restrictive VST, then you can have LV forces, which will become dominant. And if LV is more dominant than the RV, then ECG may not show RVH despite RVH being there. That's what I think he's trying to explain it. So simple Eisenmenger, you're absolutely right. Should show right axis deviation and right ventricular hypertrophy. That's perfectly fine. But if you have something on top of it, like in this particular patient, then LV forces may become more dominant, taking away the RV forces.
My own impression was more in favor of a single ventricle. With this ECG being very, very odd.
The thing is, if you take single ventricle with PAH, then again, how do you explain such a loud murmur?
At once, the Q is there that in V5, V6, there is a Q and everything. Septal forces are there. And then where is a single ventricle at all in? I do not understand really.
No, you can have single ventricle without inverted infundibulum and therefore without inverted outflow, and therefore you may have Q waves like you have in normal people.
It brings us to that Holmes heart, what I was talking about.
No, deposition of the aorta.
Normally
not Holmes
arteries, that X-ray is suggestive of a normally related rate.
Yes, that's what I'm saying. X-ray and ECG together do not fit in with single ventricle. I agree.
Let's go ahead.
This is, I think, Uma, you got another ECG?
This, I think, with half standardization.
Oh, okay.
Fine.
Okay. Yeah.
Okay.
Describe this as it is being done.
Is
the echo as it is being.
Yes. Citus solitus.
Yes.
Yes. Citus solitus levocardia with I think subcostal fourth lumbar view. Red Doppler across the interradial septum, ma'am. There is no ASD. Typical four chamber view showing cuspid wall on the right side because the septal attachment is seen. So normal aeric concordance with I think left ventricle is hypertrophied. And Doppler across the tricuspid wall, there is no tricuspid regurgitation. And, mitral wall also is normal. There is no MR or MS. There is a turbulent flow across the intercalateral septum from left. I think it is bidirectional flow.
What is the morphology of the RV?
RV looks slightly trabeculated when compared. Left
RV is normally trabeculated. Does it appear to be hypertrophied or normal thickness?
Sir, RV also appears slightly hypertrophied, sir, but I would like to measure the thickness.
Free wall, you can see it's so thick, isn't it?
Yeah, thickened.
See such a free wall.
So vessel arising from the RV. Whether it is bifurcating or not, I am not able to appreciate properly. So this is RO.
Okay, you have not been able to identify the great vessel, but the two great vessels, they are appearing from the same ventricle or
Yes, sir. Initially, the first vessel also arising from the RV. Now also the one more vessel is arising from the RV only, sir. So looking like both the vessels are originating from RV, sir. Looking like.
Where is the other vessel's origin? I didn't see that properly.
Uma, can you show the one without color where you are sweeping from one vessel to another?
Yeah.
The previous one, please. Yeah, just show this one. So this is one.
One, yes.
And then the other one comes.
Yeah, yes. Okay, fine.
The turbulence across the VSD with I think predominantly left to right, sir. So
the LV is unusually hypertrophied.
Hypertrophied, yes, sir.
Yeah,
significant hypertrophy.
Restrictive VSD.
The VSD around 6.3 mm. Gradient across the VSD is around 87 mm of Hg. So LV pressure will be like its systolic VP is 120. So around more than 200 mm of Hg, sir, LV pressure. And ejection LV ejection fraction is around 47.8 with dimensions left ventricular diastole 39 with systolic is 39 with ejection fraction of 47%.
What is the LV posterior wall thickness?
Posterior is around 14 mm, sir.
You have not been able to clearly demonstrate the vessel which is bifurcating,
yes, sir,
isn't it?
One, whether it is bifurcating or not.
That is what a little troubling.
Yes. This is.
Is the VSD dedicated to any artery or not? Is it subarterial or away from the arteries? VSD?
Look away from the artery, sir.
We're just supposing there are two vessels, you are not able to demonstrate the bifurcation. One is larger than the other. Which one would you call, which one is likely to be possibly pulmonary artery and which one is possibly aorta? There is no turbulence in any vessel.
Vessel which is larger, more likely aorta.
More likely aorta.
You
in a patient with no pulmonary stenosis.
In this way,
we are talking of a patient like this one where Uma is unable to show us the bifurcation, but she's showing us two vessels. None of them have any turbulence that you've seen. They're both opening very well. So which one is likely to be PA and which one is likely to be aorta?
Which one more dilated because of severe pH, likely pulmonary artery.
So if there is no PS, there will be PH.
PH.
In a cyanotic patient, you have PS or PH.
Yes.
Therefore, the larger one should be called pulmonary artery or likely to be pulmonary artery. Of course, you should look at bifurcation, but this is just a, a guess.
Pulmonary artery also.
Has it the suprasternal view and the aorta has been shown in this suprasternal view?
In such a situation, one view that you would use is a suprasternal view where the aorta happens to be always the superior vessel. So that's also something which you can do. Has it been done?
Yes, sir. I will show it in the next slide, sir.
Okay.
So pulmonary artery, which is more dilated, so is left and anterior to the aorta.
Yes.
So normally related arteries.
Here you can see
it is bifurcation. Yes, yes, sir.
Yeah.
Dilated PA with bifurcation.
Okay.
Yeah. And what is the aorto-pulmonary relationship now?
Now also it is pulmonary artery is left and anterior, sir. So it is normally related.
It may not be very anterior because when she was showing both the valves, they were looking at the same.
They are almost side by side. No, they are almost side by side.
Like
previous view showed it better. You know, at the valve level, we could see both were more side by side.
Correct.
That's a point in favor of a double outlet. The vessels are side by side.
Bilateral coni there, right? Meaning when in your long axis shots, they were so remote from the mitral valve.
There is a mild pulmonary regurgitation with LV function looks normal biventricular function.
And biventricular hypertrophy.
Hypertrophy. Arch. Left arch only.
Yes. No coarctation.
It's no coarctation. And there was no turbulence like PDA.
In PAH situation, what are the difficulties in diagnosing PDA by echo?
Sir, because of the severe PAH, there will be equalization of pressures, so there won't be any flow, sir, and there won't be any turbulence, so we will not be able to pick up the PDA.
Just stop, Uma.
Yes, ma'am.
I want to ask Vijay, now what is your diagnosis?
Ma'am, it is situs solitus with levocardia cyanotic congenital heart disease with decreased QP, and DORB with side-by-side related great arteries with restrictive VSD with a gradient of 80 mm of 87 mm of with severe PAH, likely Eisenmenger physiology with NYHA class 2 with normal sinus rhythm. With no signs of infected endocarditis and no feature such of congestive heart failure.
So if you're saying that he's likely Eisenmenger, would you like to catheterize him? Because Uma is just going to show CAT data. The child has been, or the patient has been catheterized. Is there any point of catheterizing him?
Because of the PR gradient, it is definitely severe PAH, but because both the arteries are arising from single ventricle, so I don't know how much reliable that we should treat as severe PAH. And the patient is also having restrictive VSD. So
are you doubting severe PAH?
No.
See, patients, whatever you may say, his PA pressure is same as aorta because it is the same ventricle supporting both the circulation. So there's no question about him having any less pH than aortic pressure. His systolic PA pressure is going to be exactly the one which is aortic systolic pressure. Diastolic and may be different, but systolic will be same. So there's no question about PA pressure being not systemic.
Ma'am, one thing we can know extra from CAT data is we can find out the PVH, ma'am, by finding out the LVDP or pulmonary capillary
How
wedge
does
pressure.
it help you in terms of his management?
If it is very high, then if you relieve the restriction, maybe the pulmonary artery pressure because of the retrograde, because of the high PVH also, that can be relieved somewhat.
Yes, so here the problem is of a restrictive VSD, and that is the reason why you want to study him and see if you can do something to him, because otherwise an Eisenmenger syndrome short of lung transplant is nothing more you can offer them. But here is a little different situation. It's not such a classical Eisenmenger that you often see. So
after seeing all these things,
sorry,
before this CAT data, that is not required at present. Can you explain now the presence of LVH, why it is there?
Sir, there is clear-cut restrictive VSD with gradient of around 80, with systolic blood pressure on upper limb was around 120, sir. So likely LV pressure
this is acting as a LV outflow, and that is obstructed.
It is like
so that is the reason of LVH.
Yes, sir.
Only there is, with such restriction and such a high LV pressure, sister, there is what you call there is a diastolic overload kind of an LVH. That's about all. I think which is a little, maybe we could have.
No,
there is.
We have not seen any LV strain in the ECG.
Not seen any strain in the ECG.
7 minutes left for this case.
Uma, go to the cath.
Yes.
Do you think any other non-invasive investigation is required for this patient? Cath is okay. We know that we have to decide the operability and what should be the operation. But do you think any other non-invasive investigation is required in this patient?
Sir, I think most of the data we got from the ECG, X-ray, and echo, sir. And maybe if the patient is going for surgery, but here is we are more in favor of to look for the restrictive VSD, sir. Like to whether we can do restrictive VSD to open it, or we need to create an extra VSD. So unlikely some other non-invasive test will be helpful, sir, other than cath data.
Okay, thank you. Please go ahead.
So here on cath data showing SVC saturation of 59 with RA saturation of 57, and there is a significant step up of around 14% from RA to RB, and RB to PA around 74 to 85, with systemic saturation around 83% cyanosis. With RV pressure, there is a significant gradient between the RV and LV systolic pressures, 134 to 230, almost 100 mm of Hg, with slightly elevated RV EDP with high normal RA mean. And the pulmonary artery, the mean pressure was around 86 mm of Hg, which is indicating severe PAH. and systolic pressures, pulmonary artery pressures are almost equal to systolic pressures, sir. And LVDP is elevated, sir. We're around 20 with pulmonary artery capillary wedge pressure of 18. So likely 12, 13 to 18. Mild PVH is there.
So do you think the echo and the cath data are concordant?
Yes, sir. Almost there where we got around 90 mm of Hg gradient from between the LV and RV. Here it's almost same, around 100 mm of Hg.
Only thing that JVP in this high pH situation you could not see. This is a bit unusual situation. At least a prominent A wave is expected.
So JVP is not elevated.
Uma, do you have NGOs or no NGOs?
No, ma'am. No.
No NGOs were done.
No
Okay,
NGOs.
Vijay, I think the final question is, what would you do for this patient?
Ma'am, because of the high gradient between the LV and RV, so we can increase the size of the VSD, or we can create one more VSD to relieve that obstruction. By we can decrease the PVH. That thing we can do, and we can start because of severe pH, we can start a vasodilator along with vasodilator therapy.
Yeah, it is unlikely that he'll be operable in terms of total correction.
So do you think that the operation, with or without operation, the lifespan would be the same or any improvement in the symptom? Why are you operating?
Sir,
are you going to change the natural history in this patient?
Yes, sir. If we Eisenmenger physiology when compared with idiopathic pulmonary artery hypertension, Eisenmenger syndrome has got good prognosis, sir, when compared with idiopathic pulmonary artery hypertension. So making the Eisenmenger into like idiopathic pulmonary artery hypertension will be worse situation, sir. So we should not intervene here. We should not do complete repair here.
What are the risks of this surgery that you're suggesting?
Ma'am, during a surgical procedure, there can be dehydration. There will be increased risk of
specific to this patient.
Ma'am, while creating VSD or increasing the size of the VSD, there can be a chance of complete heart block.
Yes, very high chance of complete heart block.
Yes.
Any other question from the experts?
There is, meaning this, what kind of a risk would be there for the surgery? What is your surgical experience tell you that what kind of a risk would be there here? High chance of complete heart block and everything. Like what Dr. Arup Das Biswas asked you, we will change the natural history of this disease. Will more important symptom relief wise. His NYHA class 2, yeah, right? If at all, what is this surgery going to offer in terms of his symptom relief? First, let's talk about that, then the natural history. By enlarging the VSD at the cost of complete heart block is what Madam also suggested. And of course, his risk for the surgery itself, even if he doesn't get complete heart block, what kind of a risk is there for the surgery itself?
Surgery also, Eisenmenger syndrome with surgery is high risk, sir. High risk surgery.
High risk, right? And to do a surgery which is not eventually going to change the physiology. What if we leave him to the natural history versus we offer him the surgery?
Yes, sir.
He's not so symptomatic. Does he require a diuretic and things like that in the history?
No, sir. He is NYHA class 2 statics in 7 years of age. So unlikely he needs diuretics.
I think the other option for you is to wait, because his left ventricle might just start failing at some point, and then you wouldn't be able to do anything. So you can closely follow him up. If his LV shows any sign of fatigue, that may be a point of enlarging his, because it's like a severe AS that he's up against.
Exactly.
So you can relieve that. We were even contemplating, doing it in the lab, stenting the VSD, withstand.
I was thinking aloud.
Simply because, as you said, Dr. Kerkar, that the surgical mortality, surgical morbidity is going to be high in this particular patient because of severe pulmonary arterial hypertension. So it's a difficult case. One could sort of, wait, not do anything right now, but once his LV tends to get dilated or dysfunctional, I think we'll have to act before that. Otherwise, his natural history is much worse than that of an Eisenmenger per se.
Absolutely.
I think the time for the case is over. And we had a very extensive discussion on this. So,
are you happy with that?
Yeah, but it's just like an exam as people do ask, you have asked in that fashion. And that is actually what is warranted.
It was a real googly. It was more a, what you call, exam of the examiners, which I quite
And from the examiner's point, I thank the presenters, particularly the boys and girls they have presented, and
Very
also
well.
the faculty from our side, and Dr. Guha for
Vijay,
arranging the session.
Dr. Uma is the faculty, is it? Because that echocardiography was excellent.
Vijay, thank you very much. Thank you very much for presenting
Thank
it.
you, sir. Thank you.
And Dr. Uma, thank you very much for presenting the investigations.
Thanks to the co-examiners also. Yeah.
Thank you.
So let us move to the next session.
What is the level of audience at present?
I have not checked. I will let you know later on.
Okay.
Now, Dr. Anita Saxena will be speaking on an approach to a patient with congenital cyanotic heart disease. May I request Dr. Anita Saxena to start her deliberation and share the screen.
Is my screen visible?
Yes.
Okay, so the experts can leave. I think they're very good experts. I don't have anything to tell them. So it is more for residents because we had a very good discussion.
We are learning a lot too, madam. Go ahead. We are there for the lecture.
So Dr. Guha wanted me to speak on an approach to a patient with congenital cyanotic heart disease. And I think we've seen one case, very sort of lot of discussion has happened, and some of it will be kind of a similar repetition that I'll go through. But just for the sake of completion, I will start with 3 cases, starting from a neonate going on to an adult. This is a few days old baby which is coming at the middle of the night. The baby is extremely blue. The emergency CMO wants us to come and have a look. The senior resident runs to see the case. Very poor saturation, 58% only. In distress, as you can see, respiratory rate is 82. What do we do next? Then I have a case who's an 8-month-old baby who came to our OPD in distress and heart failure, carrying an echo report in his hand, which shows a large AST. Reassured by the echocardiographer and the cardiologist pediatrician outside that the report only shows large AST, so you just need to stay on medical follow-up for the moment. We'll think about surgery at about 2 years or 3 years of age. So should we just let him go or go ahead and do something? And finally, I have a 28-year-old male presenting with moderate amount of cyanosis present since the beginning, almost from early childhood with clubbing. He's quite happy. He's class 2. He's able to manage his shop as usual. So what are the possibilities we are looking for in this particular adult? So as usual, for any heart disease or any disease for that matter, we go by history, physical examination, X-ray, ECG, and try and put him into a certain label as the diagnosis. So history is very, very important. In case of children, we often go by what parents tell us, unlike adults. One thing that we should remember in congenital heart disease, even in adults, is that very often they would just refuse any symptoms because they've gotten so used to this way of living that they don't even know what a normal life is. So very often they will say they're class 1, but when you actually make them walk or make them do something, then you realize they're actually not class 1. So it has to be taken very, very specifically, asking about the level of activities they can do. Like in this case, Vijay presented history suggestive of CHF in infancy. Yes, recurrent respiratory tract infections, feeding difficulties, failure to thrive. History of cyanosis, we need to know when it started, whether it started at rest or on crying. As I was telling, that some of the parents wouldn't diagnose cyanosis until the saturation has gone below 80%, but they would notice the child to be blue or the baby to be blue when the baby is crying or is feeding. And in later age group, like 2 years or so, there could be history of squatting, spells, and so on. History of syncope, seizures, global development, and then rare conditions like chest pain, stridor, etc. Family history, we need to get in every case because we know in 5-6% of cases, we may get an etiological diagnosis based on the antenatal history. On examination, firstly, the general appearance. Many of these children may actually be syndromic. Then looking for any tachycardia, tachypnea, respiratory distress, features of congestive heart failure, blood pressure at least in one lower limb and both upper limbs, then weight and height for physical development, JVP, hepatomegaly, edema, typical features of congestive heart failure, degree of cyanosis. We also do saturation. It's so easily available practically in all 4 limbs. And of course, detailed cardiac examination, including the situs, cardiac position, pulse, apex beat, left parasternal heave, murmurs, second heart sound. Second heart sound is very, very important. Therefore, we have to give a lot of importance to it. And another thing that we often forget to do is to examine over the back. Sometimes you hear no murmur, the child is blue, then you must go and examine over the back for any continuous murmurs. In children under, let's say, 2 years or so, we may not get JVP. It will be very difficult. Lung crepitations practically are non-existent. If they are there, they would indicate infection rather than heart failure. And peripheral edema is almost never seen. So we depend on a triad of tachycardia, tachypnea, and hepatomegaly to diagnose congestive heart failure in small children. Conventionally, we classify cyanotic heart disease into those with pulmonary stenosis with reduced pulmonary blood flow, typical example being tetralogy, with pulmonary arterial hypertension, typical example being complete transposition of great arteries. Then the second group that comes up later in life is the Eisenmenger syndrome, where again the pulmonary blood flow actually gets reduced. Then there are rare conditions of obstructive total anomalous pulmonary venous connections or very, very sick neonates presenting very early in life. And then we have a very specific diagnosis in adults, often in adults, although you can get in neonates also. So those with pulmonary stenosis will present at any age. So in an adult, if you have cyanosis, as I was telling to Vijay also, please always keep a diagnosis of tetralogy or tetralogy-like condition. Those with increased pulmonary blood flow like transposition will present very early. Majority of them will perish unless they are intervened in the first year of life. So an exceptional patient may survive to adulthood. Eisenmenger, please never diagnose it under 2 years, 3 years of age. It is usually a late presentation in the second decade or so. These are the sickest of all lot, and therefore they present very early, almost in the first few days of life. And Epstein anomaly, we know, can present at any age, starting from neonates to an adult. So what it shows is that age of the patient is very, very important whenever we are approaching a patient with CCHD, and therefore the set of diagnosis is going to be different at different ages. Of course, second heart sound, very important, whether it is normally split, what is the intensity of the components, what about murmurs, whether they are loud or they are soft murmurs, are they systolic? Let's talk of cyanotic heart disease as per mode of presentation. When they present with heart failure, that's usually in infancy. And this is the list. As you can see, that majority of them are CCHD with increased pulmonary blood flow like TGA, although you can also have critical pulmonary stenosis with RV dysfunction and hypoplastic left heart syndrome. Those presenting with dominant cyanosis will fall into the group of tetralogy of Fallows or similar conditions. Sometimes unobstructive TAPVC can also present like that, and certain other conditions including Epstein's and Eisenmenger syndrome. Then you may have just murmur like tetralogy of patient which are pink, just presenting with systolic murmur. And sometimes the presentation of a severe pulmonary arterial hypertension may be in the form of chest pain, syncope, or even hemoptysis like this patient had. So when we talk of a neonate, I think we need to be very, very careful because many of these newborn babies with severe heart disease can look quite well at birth, despite harboring a very serious condition like hypoplastic left heart syndrome. And the reason being that these are all ductus dependent conditions. Once the ductus tends to close, that is the time they collapse. Before that, they appear quite well. And this is the list of ductus dependent conditions. And before the discharge, I think one tries to do pulse oximetry to diagnose if they may have one of these conditions. But in our country, which is pulse oximetry is not such a commonly done investigation, and therefore many of these babies actually come back to the emergency at 2 or 3 days of life in a collapsed state, like our first patient. So in infants and children, this is the list of conditions of cyanotic heart disease. If they present with heart failure, then TGA, TAPVC, etc. If they present with predominant cyanosis, again over here, as you can see, TGA with intact ventricular septum is listed here. Other TGAs like the BSJ and all may present with heart failure. But this is a specific group in neonates where the patient may present in shock, either because of one of the PDA-dependent congenital heart diseases, like I showed, or it could also be something that we often miss is arrhythmias. So sometimes very fast ventricular rate, like in a PSVT or atrial flutter, which is more common in neonates, they can also present in a state of shock. And often we diagnose them as dilated cardiomyopathy because the left ventricle is bad on echo, but we have never looked at the ECG. So ECG will typically show you atrial flutter with the rate of 280, 300. And that is something we kind of forget because we believe that neonates can have a tachycardia, but anything beyond 220 should be taken as abnormal. When it comes to older children and adults, as you can see, the list is quite truncated. In the heart failure group, we have only pulmonary stenosis with RV dysfunction. And the cyanosis group, this is tetralogy, mostly tetralogy, and of course, certain other conditions. And one thing that gets added over here is Eisenmenger syndrome. The period dependent, of course, is out of this list, but generally these will be the conditions when we see older children and adults with cyanosis. And Fallot's tetralogy is the commonest cyanotic heart disease. In fact, even if you don't examine somebody and there is a patient beyond 2 years of age with cyanosis, if you just label them as tetralogy, you're likely to be right 80% of the time. So that is so much more common than other conditions in this age group. So here are some syndromes which give you a clue. If it is Down syndrome, please think of AVSD or atrioventricular septal defect. If it is Williams syndrome, one can think of peripheral PS and supravalvular AS. Similarly, congenital rubella gives PDA and peripheral PS, Noonan syndrome with pulmonary stenosis. This is a syndrome which we often miss. This looks quite normal looking child, but if there is flattening of the bridge of the nose, there is increased philtrum distance. So this is a classical example of 22q11.2 microdeletion. And the outflow tract abnormalities like tetralogy, double outlet, truncuses are seen in this particular syndrome. So how do we go about approaching in terms of clinical examination? When we want to differentiate between decreased pulmonary blood flow and increased pulmonary blood flow, I think age comes very handy. If you have a child who's let's say 5 years or 6 years of age, this is not the group you're going to see. But if you have a baby of 3 months or 4 months, it could be either of these groups. Again, tetralogy of Fallot's is a common disease, therefore must be thought of. Variable degree of cyanosis, histospell, histosquatting, very unusual in these patients. And I think what is very, very important over here is ejection systolic murmur across RVOTO, which is typically inversely related to degree of cyanosis. Whereas in patients of large flow, you practically have no murmurs. You have cardiomegaly, you have a lot of precordial activity, hyperdynamic precordium, but hardly any murmur. If you hear very carefully, you may get some diastolic murmurs, which are actually flow murmurs. Of course, if you have chance to get an X-ray, cardiomegaly with plethora having suggestive of increased pulmonary blood flow. So X-ray immediately will differentiate these two conditions, but I think otherwise also a murmur, a loud systolic murmur goes in favor of a tetralogy, not seen in increased pulmonary blood flow group. So within the CCHD group, how do we decide which specific diagnosis are we dealing with? It is very difficult without echocardiography. I think it is enough for us to label them as decreased pulmonary blood flow or increased pulmonary blood flow, as I showed earlier. However, there are few features that might help you. For example, having a prominent A wave, we just discussed, it could indicate tricuspid atresia more so in an adult, or it could be pulmonary stenosis with intact ventricular septum and an AST. Even tetralogies in adulthood can show you some prominent A waves because of RV becoming stiff in them. LV type of apex, I think we discussed at length, would only mean tricuspid atresia, single ventricle of LV morphology, or DORV with restrictive VASD. So it's quite a typical finding that should not be overlooked. Pulsations, the second space, again we discussed, could be because of L post aorta, could be because of single ventricle, but it can also be because of severe pulmonary arterial hypertension, like in an Eisenmenger syndrome. And parasternal heave more than grade 1, that means grade 2 or 3 is against a diagnosis of tetralogy. If it is there, one has to think of either tetralogy with a restrictive VSD or an ASD with pulmonary stenosis with an intact ventricular septum. Similarly, coming to murmurs, if there is a pansystolic murmur of AV valve regurgitation, one think of AVSD or corrected transposition, because we know MR may be associated, left AV valve regurgitation may be associated in corrected transposition. Typical early diastolic high-pitched murmur of AR would be seen in truncus arteriosus because of truncal valve regurgitation. But if you have a low-pitched EDM, like a seesaw murmur, I think that is very, very classical of TOF with absent pulmonary valve syndrome. These are low-pitched murmurs, unlike the EDM of truncus arteriosus. Block would favor towards CCTG or heterotaxis syndrome. And if we have a murmur in a cyanotic patient which is out of proportion to the degree of cyanosis, then one has to think of conditions which are tetralogy physiology, like transposition, but not tetralogy. Because here in transposition, there are two reasons for cyanosis. One is the admixture, and other is the pulmonary stenosis. So there'll be more cyanosis with the loud murmur itself. So coming to this group in briefly, I think these are the various differential diagnoses which often, the residents are asked to enumerate during their examination. What are the various tetralogy fellows like conditions? And, I think we've had a list of these. We talked about some of these in our case also. Primarily, what it has is reduced pulmonary blood flow and normal or less than normal pulmonary artery pressures. So that is what is hemodynamically tetralogy or tetralogy physiology, that we have a flow which is reduced and the pulmonary artery pressures are normal or less than normal. Generally, these patients will have normal growth and weight gain, and they also have a very loud or at least some murmur, like a systolic thrill and ejection systolic murmur, which I mentioned earlier also. There will be no evidence of heart failure in these patients, unless for some reason an adult with tetralogy has gone into heart failure, which we know are very specific causes. X-ray is quite typical, no cardiomegaly, maybe a right aortic arch in some cases, 25%, and pulmonary oligemia. There is no prominent hilar markings as we were seeing in the previous case, but you can have sometimes very typical X-rays. For example, this one is an LV apex, and you can see here the right atrium is actually gone behind the sternum, and this is called RA cutoff sign in a tricuspid atresia with juxtaposed RA appendages. You can sometimes have a hump at the left cardiac border, which is because of the inverted infundibulum, and that is single ventricle. Very typically, if you have a mismatch between the situs of the heart and situs of the viscera, like here we have levocardia with situs soletus, or you can have mesocardia with situs inversus soletus. Always think of atrioventricular discordance or ventricular inversion, and this typically shows the dilated left ventricle, dilated L-post aorta in a patient of CTGA, VSD, PS. TOF absent pulmonary valve may have cardiomegaly, but has very prominent either both pulmonary arteries or at least one pulmonary artery, and there is total oligemia. As you can see, the peripheries are totally black. There are no endone vessels. It is only the pulmonary artery which is very much dilated. ECG again will give us to some extent a diagnosis. This is classical tricuspid atresia. If you have this ECG of left axis deviation and left ventricular forces, no right ventricle, there is absolutely no question about the diagnosis. It is tricuspid atresia. In adults, you may get sometimes right atrial enlargement over here, which is akin to a prominent A wave in the JVP. But in a classical tetralogy, we get right axis deviation, which is not extreme, more like plus 135 or so, and early transition. So if you have V1 here, V2 shows early transition. There is immediately S wave appearing in V2. So this is pretty classical of tetralogy of Fallows, although rarely it can be seen in other conditions. Now, this is an ECG where you see much extreme right axis deviation. As you can see here, it is almost going to 150, 160. There is so much of right ventricular hypertrophy. There is no early transition. And in fact, there is STT changes. So this is very atypical for a tetralogy of Fallows. And here we could even think of severe pulmonary stenosis with intact ventricular septum with an ASD, and that is why the patient is blue. Or it could be tetralogy with the restrictive VSD, again RV pressure becoming suprasystemic. So this is suggestive of the fact that RV pressure is not systemic but suprasystemic. This is another adult with cyanosis, again grade 3 murmur, looks like tetralogy. However, the pulse rate was only 60 per minute, and the moment you see a heart rate which is so slow and an ECG showing complete heart block, one should always think of corrected transposition VSTPS, because that may be associated with complete heart block, and patient may be totally asymptomatic of the block. Increased pulmonary blood flow, this is a list of conditions which you often see only in children or let us say infants. So very early presentation, variable degree of cyanosis, and early infancy cyanosis may be very mild, and then it tends to increase over a period of time. All the features of large flow like failure to thrive, recurrent chest infections, cardiomegaly on X-ray, maybe third, fourth heart sound, precordium hyperdynamic, very soft murmurs, hardly any systolic murmur. Practically, if you hear very carefully, you may hear diastolic flow murmurs at the apex and lower sternal border, and X-ray will be typically cardiomegaly with pulmonary plethora. So this is an X-ray of Egon side, as you can see here, with very narrow pedicle and increased pulmonary blood flow. This is X-ray showing figure of 8, but remember this figure of 8 only comes beyond 8 or 9 months of life. It's unlikely to be seen in very small infants. And this is a patient of truncus where you see the pulmonary arteries coming very high. This is called a watershed sign, where the pulmonary arteries seem to be coming much higher than its usual location, and that is quite typical of truncus arteriosus. So you may get an idea of the type of CCHD in an infant based on the X-ray, or a child. However, very often the X-rays are not so typical as I have shown here. What it will show is cardiomegaly with increased pulmonary blood flow, that's all. If you see narrow pedicle, you can probably think about great arteries being transposed, like in transposition of great arteries or other such conditions. One condition where you don't get cardiomegaly is this one, obstructive TAPVC, where you have practically normal size heart with ground glass appearance of the lungs because of severe pulmonary venous hypertension. So although we put it in the cyanotic with increased pulmonary blood flow, but this is more of a sort of an emergency situation, and these babies present much earlier in life, usually in the first week or 10 days of life. And this looks like an X-ray of an ARDS, and therefore one needs to differentiate this from the X-ray of an obstructive TAPVC, and X-ray and the echo would be the final answer for the diagnosis. Now coming to adults, I think these are the two major conditions that we talk about, tetralogy or Eisenmenger. And often the question is, how do we differentiate? I think we need to remember that pulmonary blood flow is reduced in both these conditions. In tetralogy, the obstruction is because of anatomical obstruction leading on to infundibular obstruction. Therefore, the pulmonary artery pressure is going to be low or at best normal. On the other hand, in an Eisenmenger syndrome, the pulmonary blood flow is reduced, but it is reduced because of very high pulmonary vascular resistance at the capillary level because of medial hypertrophy and narrowing of the capillaries, and that leads to very high PA pressures both in the main and the right and left pulmonary arteries. So this is also reduced pulmonary blood flow, but the reasons are different over here. X-ray, yes, it will differentiate. It will show no cardiomegaly, lung fields being black. On the other hand, in Eisenmenger, as we just saw the X-ray, there will be very prominent pulmonary artery segment, prominent right pulmonary artery, sudden tapering of right pulmonary artery, and peripheral oligemia. However, at the bedside, this is how we should go about. If you have history of failure of growth, failure of weight gain, history of heart failure in terms of feeding difficulties, you should opt for Eisenmenger physiology, like we saw in our case. Squatting, very uncommon in Eisenmenger. Syncope, more common in Eisenmenger. Hemoptysis, although can happen in adult tetralogies, but Eisenmenger patients more often have hemoptysis as a presentation, and chest pain and angina are again part and parcel of severe pulmonary artery hypertension, therefore more likely to occur in Eisenmenger physiology than tetralogy of Fallows. And also the history of cyanosis likely to be late in an Eisenmenger secondary to left to right shunt. Not the case like we saw today. If it is a case of admixture lesion, then cyanosis will come earlier. On examination, again, we may get A wave in JVP in both tetralogy and in Eisenmenger syndrome. But what basically differentiates the two is a dejection systolic murmur. And that is, I think we were trying to emphasize in the case that we just saw, that if you have a loud ejection systolic murmur in a blue patient, do not go for Eisenmenger physiology, you should go for tetralogy, because we know there is no reason for ejection systolic murmur in Eisenmenger, but then there are exceptions like we saw the case today. So having an early diastolic murmur goes in favor of Eisenmenger, but a loud ejection systolic murmur will always go in favor of tetralogy, and we must keep that as the first diagnosis in anyone presenting with cyanosis in adult life with loud ejection systolic murmur. Now, once we have decided that this is a case of Eisenmenger syndrome, the next question often asked from the student is, where is the Eisenmenger occurring? Is it occurring at the ventricular level, ductus level, or a atrial level? I think the first thing is that having an Eisenmenger in an ASD is a little unusual. Therefore, one should keep a very low threshold for diagnosing ASD in an Eisenmenger. It is more likely to happen in VSD PDA, especially the large shunts. And the age of onset of Eisenmenger may come early, but their presentation is usually late. Differential cyanosis, if present, will help us because it will be in favor of a PDA. But remember, it is seen in 50%, not everybody. And you have to really keep the foot and the hand together to appreciate it, because both are going to be blue. Saturation may be a little different, and unless you keep them together, you might miss differential cyanosis. But it is the second heart sound which is supposed to give the maximum information on the underlying heart disease. And here we know that in VSD it is single, in PDA it is usually normal or narrow with a loud P2, and it remains wide and fixed split in an ASD. Again, just a word of caution, we should not make a diagnosis of Eisenmenger syndrome in a child less than 2 years or of age or so, because these are the children who may be still operable, or they are having an admixture kind of lesion producing cyanosis. So please do not diagnose Eisenmenger in young children. X-ray can be helpful. Of course, it shows absence of cardiomegaly with prominent pulmonary artery segment, prominent right pulmonary artery. But in an ASD, you would see more of right atrial enlargement. So this also helps us to differentiate the two. There will be cardiomegaly in an ASD, which is not usually the case in a VSD or PDA. In VSD, you may get a little bit of left atrial enlargement sometimes, but remember, there will be no aorta here. Aorta is not dilated. Whereas in a PDA Eisenmenger, the aorta is likely to be prominent. And in fact, one can sometimes see a PDA. That means between the prominent pulmonary artery segment and the aorta, one can see a fullness of this segment. At times in adults, in 30s and 40s, you may even see a calcium over here because of calcification of PDA. So PDA will give dilated aorta, dilated pulmonary artery. ASD will give dilated right atrium and cardiomegaly. And that is how you can differentiate the three levels of Eisenmenger. ECG typically, I think as we discussed, will show right axis division with right ventricular hypertrophy. If it shows good left ventricular forces also, like in this particular child who has got a right axis deviation, as one can see, but there are good left ventricular forces. There are even Q waves in V5 and V6. Again, we should not diagnose them with Eisenmenger syndrome. These are the children who may still be operable. Therefore, a cardiac catheterization, perhaps with a vasodilator testing, is what is required to be very sure that they could be operated or not. So therefore, again, in young children, one has to be more careful. One has to look for features of left ventricular hypertrophy or volume overload in addition to RVH to say that they could still be operable and not Eisenmengerized. Certain unusual conditions, before I finish, this is, I would say they are a little rare compared to the other condition we discussed. Unobstructed TAPVC in adult will present like an ASD with minimal cyanosis. Sometimes one misses cyanosis and diagnoses them as ASD, but the X-ray which I showed you with the figure of 8 is quite typical. Common atrium, although still operable, normal PA pressures can also give features of ASD and a little bit of cyanosis because of the mixing of the blood in the atrium. And of course, Epstein anomaly is a very specific diagnosis where it can present at any age, but often you will see an adult who's very minimally symptomatic, may have some history of palpitation. Examination will show you absolutely quiet precordium with multiple heart sounds and a soft early systolic murmur of tricuspid regurgitation. X-ray showing a big heart, and this is quite a classical X-ray of a Epstein anomaly where you have RBBB, but it is only the later part of the bundle which is delayed. So it appears as if there are two QRSs. One is sharp and one is broad. So this is quite typical of an Epstein's anomaly, X-ray as well as ECG. So it can present at any age, but in neonates it's much more severe in terms of severe cyanosis and heart failure, but in adults it is much better tolerated. Rarely you may have absolutely normal examination, split being normal, no murmur. One has to think of these three conditions. X-ray may give you a, like a suggestion of a pulmonary fistula sometimes, but often it is normal, and an echo with saline contrast is what is required to make a diagnosis of any of these anomalous systemic venous drainage conditions or pulmonary AV fistula. So I just to sort of reiterate, if you have a neonate or an infant, this is the list of diagnoses you should entertain. Fallows again is right on the top, as you can see. And smaller babies or in infants, you can think about TGA, TAPVC, truncus arteriosus, etc. But when it comes to adults, again, tetralogy remains on the top, but Eisenmenger syndrome also comes close by. And therefore, these are the two conditions one has to think of in an older child or in an adult. Coming back to my cases, this is the first case. The question is, what would we do next? As you can see, PO2 is very low, 29 only. Saturations are also very low. So don't worry about an echocardiogram. Immediately start PGE1 because this is a child who will be harboring a ductus-dependent congenital heart disease. And PGE will definitely improve them, whatever the diagnosis is. So this baby turned out to be having transposition with intact ventricular septum. PG stabilized the child. Of course, child later went for balloon lateral septostomy. This is the second child that we talked about who had diagnosis of ASD from outside. But if you look at the X-ray very carefully, although it's not typically figure of 8, but there is something happening over here which may be suggestive of TAPVC. And therefore, this is the patient whom on echocardiography, as one can see, showed right ventricle, right atrial dilatation. ASD is actually going right to left. And that is the best clue to the diagnosis that ASD going right to left means total anomalous pulmonary venous congestion in an infant. And therefore, the diagnosis changes, the management immediately changes, and therefore, we must not ignore an ASD who's in distress or who's in CHF. There could be many reasons for it, but one of the treatable conditions is total anomalous pulmonary venous connection. And finally, this 28-year-old male presenting to the OPD, what are the possibilities? First, tetralogy or one of the tetralogy physiologies, Eisenmenger syndrome, Epstein's anomaly, and then some other condition like TAPVC or a rare condition like the one we had today, which is exceptional survivors of complex congenital heart diseases. So how do we go about it? If there is no left parasternal lift more than grade 1, single second heart sound, loud ejection systolic murmur, tetralogy becomes the first diagnosis. If the precordium is quiet with multiple sounds, very soft murmur of TR, Epstein's anomaly becomes the diagnosis. If you have all the features of ASD, including ejection systolic murmur at the base and a flow diastolic murmur at the lower left sternal border. Think of TAPVC. And if we have, again, a loud second heart sound with practically no murmur or very soft murmurs with no left parasternal lift, again, it would point towards Eisenmenger syndrome. So to some extent, you can make these differentiations. So therefore, a systematic clinical evaluation will help in categorizing the CHD. ECG X-ray are very important. Echo, of course, will give you the diagnosis, but it must be supplemented with good clinical data. And therefore, clinical examination remains very, very important, even for people doing an echo. One can make a lot of mistakes on echo if one is not fed with the clinical data of that particular patient. And before I end, I think one exception we've just seen, grade 5 murmur in Eisenmenger syndrome. And there's another lady that we had, 17-year-old girl, followed up as a large VSD with Eisenmenger syndrome. Something odd, she was very blue. At 17-year-old Eisenmenger having 72% saturation would be rather unusual. And she also was very symptomatic. So she was considered inoperable based on her X-ray examination and all. But what we found was that in addition to the large VSD, as you can see, which is shunting a little bit to the right to left on contrast echo, she also had some turbulence at the pulmonary venous site. This is the right pulmonary vein, which showed some turbulence. So when we interrogated the pulmonary vein, one can see that there is pulmonary vein stenosis, which was producing pulmonary venous hypertension in addition to her Eisenmenger syndrome. So she underwent a balloon dilatation of the right pulmonary vein as a palliative procedure. She did improve to class 2. More importantly, her saturation improved significantly from 72% to 88%, although she has had some amount of restenosis of the pulmonary vein of the last follow-up. Thank you very much for your attention.
Thank you, ma'am.
Thank you very much.
Hello.
For this. Rakesh, yeah, go ahead.
Yes, yes, sir. I'm not finding any question in the chat box.
There is
I
one
was
question.
searching for that.
There is only one question. Mechanism of squatting in Eisenmengers, how to explain?
Yes, I think squatting the mechanism is to be explained in a similar way as tetralogy, although squatting is quite unusual in Eisenmenger syndrome. And even if the child squats, the improvement is not so much as you get in tetralogy of Fallot's, because there is some amount of dynamic obstruction in tetralogy, which is not the case in Eisenmenger. So it's rarely described, but I would say that if there is history of squatting, I would tilt towards tetralogy and not Eisenmenger syndrome.
I believe he's asking about the mechanism. What very many mechanisms. The most important mechanism is the PVR, right? Yeah. The peripheral vascular resistance. That goes up with squatting, and the right to left shunt decreases. So the same, that is the same all-important mechanism, but there are other things that people expect as answers. So like you got all the deoxygenated blood down in the legs, less deoxygenated blood coming up. That's what it is. But the most important
since the SVR increases, therefore the right to left shunt decreases even in Eisenmenger syndrome. So it is the same mechanism. But for some reason, it is not seen in Eisenmenger. And I would believe the reason is that Eisenmenger does not happen at the age when squatting happens. Because Eisenmenger is usually a late phenomenon, and squatting happens in the first 3 or 4 years of life. And once the child becomes more conscious of the people around him, he stops squatting. And therefore, squatting is not seen in Eisenmenger syndrome. Otherwise, the mechanisms are not very different.
I'm not seeing any other question in the chat box. If there is any other question, please type it down right now. And may I request all the panel of examiners, anything relevant you feel, you may discuss. We have another 10 minutes left.
Why no squatting in TGA is one question that's come up from Darshan Kamath.
Yeah.
Is clubbing reversible in CCHD after corrective surgery is one question.
No, mechanism of squatting in Eisenmenger, that is a question.
No, that we've done.
That has been discussed.
So the second is
reversible in cyanotic congenital heart disease.
Right. So clubbing is reversible to a large extent, but somebody who has developed grade 4 clubbing may not reverse totally to normal. There may be some amount of clubbing left despite the fact that the cyanosis has gone, because a lot of hypertrophy has happened and it may not reverse completely. So in children, when you operate, the clubbing usually goes away, but when you're operating in an adult with significant or advanced degree of clubbing, one may not completely reverse it. The second question was no squatting TGA. So I think we did explain that TGAs have such a poor prognosis that 90% of them will not survive beyond first birthday. And therefore, the number of TGAs that we see in older children is much less than the number of tetralogies that we see in older children. And therefore, to give you a data on squatting in TGA will be very tough because the number of cases is going to be very slow. I'm sure if we look at all TGAs, some of them will give you history of squatting because it helps them, like in Eisenmenger syndrome, that it helps in improving their right to left or decreasing their right to left shunting. But as it is, the group of Eisenmenger is very unusual or very uncommon in an age group of 2 years or 3 years of age.
Why hemoptysis is more common?
Yeah. More common in Eisenmenger. Okay. So hemoptysis can occur for various reasons. One of them is rupture of small pulmonary arteries or pulmonary arterioles which are exposed to very high pressure, and therefore it is more likely to happen. Whereas in a tetralogy, the hemoptysis is more because of rupture of the aortopulmonary collaterals. So as it is, hemoptysis points more towards severe pulmonary artery hypertension. I wouldn't say Eisenmenger syndrome, I would say severe pulmonary arterial hypertension.
Any other comments from any expert?
Comment, it is a very commendable presentation. First thing, brilliant presentation, I should say. It would help not only the students, but confirmed cardiologists like us also for recapitulation purpose. Now, I don't think we don't have enough time left. Otherwise, I could have gone to another topic, like how do we see post-operative cases, because many of the, it's not for the students alone, but the adult cardiologists. At times we have to see post-operative patients. Nowadays they are accumulating in India gradually. So do you have some time to discuss about that?
We have another 10 minutes time, but there is a question. Expected changes in clinical examination in ASD, VSD, PD after Eisenmenger's. It is directed to Dr. Saxena.
Yeah, so I think I did discuss a table where I showed the differences between ASD, VSD, and PDA level of Eisenmenger. I would, if that is the question, I would repeat it. In ASD, firstly, Eisenmenger occurs much later. And some believe that Eisenmenger at all in ASD, it is more of pulmonary arterial hypertension associated with ASD. But anyway, I think if we say ASD, Eisenmenger, the age group is going to be in 40s, except a small group where you may get an early Eisenmenger. Whereas in VSD, PDA, we are likely to see these patients in the early second decade or that they may Eisenmengerize by 10 or 11 years also. Differential cyanosis, PDA or pulmonary regurg more often seen in PDA company or ASD, unless patient has gone into failure, which is much later in life, maybe in 50s. There is no cardiomegaly in VSD and PDA. There's no heart failure. There's no TR murmur, something that you may find in ASD patients, cardiomegaly and TR murmur. It is the second R sound which is very important. It is single and loud in VSD. It is wide and fixed split in ASD. And pre and post tricuspid Eisenmenger syndrome history-wise other than age. So yes, history of recurrent chest infections during childhood or during infancy is something that you don't see in ASD, but you do see in VSD and PD or post tricuspid shunts. So history of failure, history suggestive of heart failure, history of recurrent LRTI, failure to thrive, all those features would suggest a large post tricuspid left or right shunt. Most of the ASDs, even if they are large, are asymptomatic or very minimally symptomatic in infancy. So that history will also help us to decide whether it is post tricuspid or pre tricuspid shunt, which is giving Eisenmenger. Can we decide about the site of arch on lateral film? Well, I'm not aware of it. I think we can decide the site of arch on AP film very well by looking at the indentation on the trachea. Whichever side is indentation present, you usually say the arch is of that side. Why there is Can we prevent student knowing the diagnosis before presentation? Good question. I don't think I can answer it, but you are absolutely right. I think that is what happens. I don't know, Vijay can probably tell us if he knew the diagnosis or not. We tried to keep it a secret as much as we could, but yes, absolutely. I mean, in the exam, as an examiner, I get a very bad impression if the student knows the diagnosis. Even if he makes 100 mistakes, not knowing the diagnosis is so much better. At least you know your thinking process is right, your synthesis of the findings is right. And even if you end up making a wrong diagnosis, I don't think I mind. So I'll be happy if the students don't know their diagnosis.
May I make a comment regarding this?
Sure.
If the doctor knows the diagnosis and presents the case, his vision becomes absolutely tubular, and he cannot deviate in the discussion any differential diagnosis, any chance of being wrong, any finding. He cannot analyze. Only one thing. He is going uttering and muttering only one thing. This is the diagnosis. This is the finding.
Agreed. Absolutely.
Yeah, I would advise the students that as soon as you get into the examination hall, tell your supervisor, internal guy who's there, that please don't tell me the diagnosis. However, when I finish everything, I'm ready to go. Come and tell me the diagnosis, just in case I have to revise anything. And invariably, you come across everywhere the student knows the diagnosis and he messes up big time.
Absolutely.
So you are good enough. You've seen so many patients over the years. You can think for yourself. Especially after your history, if you learn to keep your physical findings away from history, then you think better,
Right.
Few more questions in the chat box.
So I think when we go for DNV exam, because the student is in a different center, then many a times they don't know the diagnosis. And I think the exam is much better when they don't know the diagnosis.
Agreed, always.
We are here to just judge their way of looking. We are not here to judge their diagnosis, because these days with echo being available, everybody can make a diagnosis. It is the thinking and the synthesis of the findings and history that we are looking at as an examiner. And that is what I think is important, more important than making the right diagnosis. So while the split is fixed in ASD even after Eisenmenger, I would say the same reason which are there for making the fixed wide split in an ASD continue to be there. That means the respiratory variation affects both the pulmonary and the systemic circulation in the same way, and therefore the split remains wide and fixed. Cause for early transition in TOF, ECG. I think this is a common question which personally, I would say I don't know the answer, but the answer that most of the examiners want is because there is a large VSD lying underneath the V1 and V2 site of the ECGs. Therefore, you get a sudden transition because there are no forces coming at the level of large VSD. That is usually the answers I've heard, examiners asking for. Patient with BT shunt, how does clinical examination finding change? Well, you will get a continuous murmur of BT shunt. Rest will stay the same. Causes of cyanosis with continuous murmur, pulmonary atresia with VSD, the commonest one. You can also have a tetralogy sometimes with large AP collaterals producing continuous murmur. And rarely you may have a continuous murmur in an obstructive TAPVC, where the continuous murmur is coming from the site of obstruction where the jet is going. So you may get it on the left side if it is a left vertical vein, or on the right side if the TAPVC is happening to the right side. So that's a rare cause, I would say. How to differentiate clinically between single ventricle and TGA? I would say that if it is large flow situation, it will be very hard to differentiate. They'll almost behave in the same way. If it is a reduced pulmonary blood flow situation like a tetralogy, then it may be easier. TGA patients are going to be much more blue than patients of single ventricle for the same amount of murmur. So TGA will have a disparity between the loudness of the murmur and the degree of cyanosis, which is unlikely to be there in single ventricle. Similarly, as we discussed, you may have a dullness on the left second intercostal space because of L position of the dilated aorta in a single ventricle, which will not be there in transposition. Second heart sound will be single in both of them. I think I finished with all the questions.
Another question sometimes asked is why a few patients, very few percentage of patients of ASD goes into failure very early in life.
Right. So I think the figure is like 8% or so of these ASDs go into
single
failure.
digit.
Yeah, in early life, and these are real ASDs. They're not TAPVCs or something which we are missing. So couple of things that have been talked about. One is that patients has a very stiff right ventricle, which is not able to take the volume that is given to it because of the large ASD. So they tend to behave in a way of, diastolic dysfunction of the right ventricle, producing features of right heart failure. We have seen in some patients, I think it's written also, that a dilated coronary sinus, which is basically left SVC to coronary sinus, which is a common association with ASD. A dilated coronary sinus sometimes can impinge on pulmonary veins or some structure and can give failure in these patients. So many of the patients of ASD actually have a very large coronary sinus if you look at their echo, and that could be responsible. Yes, there is a small subgroup, and ASD closure helps in these patients actually.
I think our time is up, and I thank everybody. Dr. Anika Saxena, Dr. Venugopal, Dr. Praful Kerkar, Dr. Arup Dagviswas, and Dr. Rakesh Yadav. Dr. PK Dev has also joined. Sometimes I don't know whether he is there. Still not.
Chandra, I'd like to thank the case which is presented from AIMS.
Vijay.
It is amazing because we all got caught. See, I actually
Vijay, thank you very much.
The echo came along.
Now, this is one of the very few cases of Eisenmenger's with a long murmur I have seen, to be very honest.
Yes.
I think you do have the same experience.
Actually, I made a diagnosis of reduced pulmonary blood flow. I made a diagnosis with tetralogy, single ventricle with tetralogy myself. And we were quite surprised when we looked at the X-ray. That X-ray is so much against, tetralogy.
Your comment that the LV pressure is 230 is just almost like a aortic stenosis.
Aortic stenosis.
Just like a subaortic stenosis sort of a thing, which happened.
Yeah.
So thanks to Vijay and Dr. Uma for presenting this case and the investigations. And I thank all the viewers for
big clap for
being with us for the entire duration of time. And we will be meeting again after 2 weeks on Sunday at 11 o'clock. And all the programs and everything will be sent to you in course of time. Thank you very much.
I have just one request.
Yeah.
I would appreciate the feedback from the students if you can get it.
I will try. I will certainly try, and I'll give you.
Thank you.
Thank you.
Thank you
very much.
Thank you, sir.
Thank you.
Bye.
Thank
you,
Nice
Shantanu.
meeting. Nice meeting all old friends and all co-examiners in the same platform.
Thank you.
Okay.
Bye.
Thank you very much.
Bye.
Bye. Bye.